Thank you very much, and thank you to the Association for the invitation to bring you an update on this technology, which is a prolonged cardiopulmonary bypass going by the name of ECLS or ECMO. This young man was a student at Indiana University several years ago. He was healthy one day, dying the next day of meningococcal sepsis. And when his local docs did all they could for him, they called us to say this young man is dying of heart failure, lung failure, renal failure, liver failure. His brain is we don't know about, but would you come and consider putting this kind of patient on ECMO? And of course, that's exactly what we do. This is his X-ray, and this young man is on several artificial organs, an artificial lung, a kidney, a heart, and most importantly, an artificial gut, the artificial organ that we don't credit as much as we should. Taking care of a patient like this is an exercise in cardiopulmonary physiology, and I tell our residents that if you learn everything on this slide, you have 80% of critical care. That's all you need to know about, and particularly his metabolism is going on at a certain rate, consuming oxygen, producing CO2, and in this case, neither his heart nor his lungs work well, so we have to mechanically replace these aspects of his physiology. So this technology is variably known as extracorporeal life support or extracorporeal membrane oxygenation. Not a very good description of what happens, but it only has 2 syllables, so we stay with it. And this refers to mechanical support of heart or lung function, which is temporary, meaning days to weeks, nowadays to months of time, can be partial or total support, can avoid ongoing iatrogenic injury. This doesn't treat anything. It simply keeps the patient alive, but allows us to turn the ventilator down to low pressure, low oxygen, get away from all the chronotropic and inotropic drugs, letting those organs hopefully recover at rest, or if they don't recover, to consider bridging to transplantation or replacement in the sense of a heart. Indications for doing this are easy to describe in adjectives, much more difficult to describe in nouns. What constitutes cardiopulmonary failure that is unresponsive and going to have a fatal outcome? But we have pretty good ways of measuring that in all different age groups. A quick summary of the history is shown here. This is Phil Drinker, an engineer at the Brigham Hospital in Boston, and Phil and I got working on using membrane lungs instead of direct gas exposure lungs for cardiopulmonary bypass, and it turns out that allowed us to manage extracorporeal circulation for days at a time. This dog was on for 4 days, pretty exciting stuff in about 1968. The first clinical application was done by Don Hill in San Francisco, and this patient survived with ARDS with extracorporeal support in 1971. Al Gazzaniga and I did the first cardiac case in 1972 and the first newborn case in 1975. This is the technique that we used for children, where most of the application was going on in the early days, and you recognize simply a stripped-down heart-lung machine with right atrial access to the jugular vein, a pump, a membrane lung, something to heat it up again, and putting the blood back in the systemic circulation, in this case through the carotid artery. Those cases were done in the 70s, and there was considerable interest in this technology. This represents the number of centers involved over time. This is the number of cases involved over time. We moved from UC Irvine to University of Michigan in 1980, where most of the further development of this technology has taken place. This actually became standard treatment for neonatal respiratory failure in 1986, and the Extracorporeal Life Support Organization that I'll tell you more about was established in 1989. So as a device to support either heart or lung or both function, we have to apply it in different modes, as you might imagine. If the problem is circulatory support for heart failure for any reason or an association with CPR, or nowadays we use this in dead people to resuscitate organs for transplantation, veno-arterial access is necessary, just like conventional cardiopulmonary bypass, and we do this with the access that's already there. If a patient can't come off the pump in the operating room, if the chest is closed, we can get access via the neck vessels or the groin vessels and use direct access if it's a patient coming out of the OR. For respiratory support, veno-arterial access works just fine, but veno-venous access works as well. That is taking blood out of the right side of the circulation and oxygenating it, removing CO2 and putting it back into the right atrium where it mixes with the native venous flow, but that's adequate to support all of gas exchange. Obviously has no effect on hemodynamics, so a VV patient needs to have normal cardiac function. And once a patient is on this apparatus, then we've learned to rest the lung and rest the heart, turning them down to very low settings, turning off the vasoactive drugs by and large, and maintaining that until the native organs have recovered enough to be able to wean the patient. This has required a group of people just to look after this technology at the bedside. ECMO specialists, and I'm sure all of you have this type of a group in your hospital somewhere. What we've learned more recently because of advances in technology is that this can now be managed by the ICU nurse, who has to be there anyway, with some extra training. There's still a need for ECMO specialists, but mostly in an educational and advisory role. And this is now routine ICU procedure in most major pediatric, neonatal, or even adult ICUs. I mentioned ELSO. This is a consortium of the medical centers around the world that use this technology and study it in detail. There's some 400 member centers now, so these are the distribution of the ELSO members. And what ELSO does, among other things, is to maintain a registry of cases, beginning with the first patient and up until the present time. So there are now about 70,000 patients in the registry, and they fall into these categories, as you can see: neonatal, pediatric, or adult patients with respiratory cardiac failure or ECPR, that is using ECMO in conjunction with CPR for cardiac arrest. We'll talk more about that later. As you can see, the survival to discharge numbers run from 80% to 30%, depending on the type of patient, which of course means that a lot of people die with this circumstance, but we only use this for people that we think are going to die otherwise, so that those results are reasonable, but we have a lot of room to improve. These are the types of cases in the registry over the last 20 years, and you can see that initially they were mostly neonatal cases with respiratory failure, and the percentage of neonatal cases is now quite small, with pediatric and adult respiratory failure and cardiac failure being the primary indication around the world currently. So for cardiac support, we use veno-arterial access. In this particular patient, we have access through the jugular and carotid. You really can do that in an adult patient. And here's a patient who's alert, awake, extubated, breathing just fine. His only problem is his heart doesn't work, and he's bridging to an LVAD. These are the cardiac cases in children over the last 20 years or so. And you can see that there are about 800 cases per year in the registry. ECMO is the only mechanical support system for children, especially small children, until the Berlin heart became available. So it really was the only way to manage severe cardiac failure in children. These are adult patients, and notice the use picks up a lot in about 2009, and we can talk about the reasons for that. the current algorithm for using ECMO for cardiac failure is shown here. The heart might recover quite promptly if it's myocarditis or myocardial stun following a long cardiac operation, or the heart may be totally dysfunctional, and if it's not working a bit by day 2 or 3, it's probably never going to work. So our algorithm is this. If on day 2 or 3, if heart function is returning, good, that's going to lead to recovery most likely. If not, then is the patient a transplant candidate because the heart's probably not going to get better? If the answer is yes, go to list the patient on the list. It's going to cost somebody about $1 million to do that. If the answer is maybe, then bridge to a VAD to go to recovery. If the answer is no, then draw yourself a line and say, if this heart's not functioning by day 6 or 7, we should stop doing this. So long-term ECMO for cardiac failure is really not an indication. You either go to a VAD or the heart recovers or stop. In neonatal respiratory failure, you can see that the peak use here was in the early 90s, and then the use of ECMO for neonatal respiratory failure has been getting less every year for good reasons. One is that during the early days here, the treatment of neonatal respiratory failure was induced hyperventilation to get the pH around 7.5 or 6, which it was thought would open the pulmonary vasculature. Turned out not to work, but by simply stopping to do that, the results, of course, were very good. And then the mid-90s came nitric oxide. So inhaled nitric oxide is we use it all the time. It's not good for much, as you all know, but it's really good for neonatal respiratory failure with persistent fetal circulation. The results of neonatal cases are shown here for different diagnoses. This is meconium aspiration. This is viral or maternal sepsis. The one diagnosis that's getting worse over time is congenital diaphragmatic hernia. And the reason is that in the early days, we only used this for children who already had their hernia repaired. They looked pretty good. Now they've failed the honeymoon period, if you remember those years. Then we began to use it for all children with diaphragmatic hernia. Then we began to use it in utero in some cases with severe defects. And so these children live or die based on how much native lung they have and how much it can grow over time. We're working on ways to induce lung growth in those babies, and that's an interesting application. Pediatric respiratory failure is a little less frequent, but when it occurs, like the young man that I just showed you, it can be a serious problem. Notice that, like all the other applications, this increases a lot after about 2009. The results in pediatric respiratory failure cases are shown here for different diagnoses, and in all these diagrams, you can't make too much out of the individual survival rate because of small numbers of patients. But since about 2009 or 10, you can see that the survival for ARDS, bacterial pneumonia, viral pneumonia, aspiration, and so on, is about 60+%. With adult respiratory failure, not many cases were done in the early days, partly because of an ill-conceived study that was done in the 70s looking at ECMO for the new diagnosis of ARDS where it had no effect. That study was really poorly designed, and I can say that because I was one of the people who designed the trial, but that essentially stopped research on adult respiratory support for many years until about 2009, and two things happened at that time. One was the H1N1 flu epidemic, which you probably remember, where the use of extracorporeal support was the only intervention that resulted in improved recovery, and in fact quite good recovery, 70–80% survival. The other is new devices and technology that I'll tell you more about. So the application in adult respiratory failure is now about 2,000 cases per year. The results are shown here. Again, hard to make much of this, but for the last several years, it's running at about 60% survival on average for all the various diagnoses that you might imagine. Those registry data include probably half of the ECMO cases done around the world by the member centers, but it does represent the data from the centers that are really good at it, know how to do it, and so on. So that's kind of the optimal that you might hope for. For all those early years, the ECMO machine, if you will, looked like this. You bought a pump from one place, an oxygenator from another place, and a heat exchanger from someone else, and put it together in your garage and hooked it up, and it worked, but it was pretty tedious. In 2008, 3 companies in Germany decided to build ECMO machines. The first and the most active was the McKay company, and they really simplified the circuit, make it much more easy to use. Novalung and Sorin are the other companies, and they're not available in the United States. So we've been using the McKay ECMO system for 6 or 7 years now. And that's made a huge difference. First of all, it's much simpler and safer to run, much less bleeding as a complication, and it's changed our management of patients. So during that time, we've gone from heavy sedation and paralysis to waking these patients up, have them breathing spontaneously, sometimes exercising out of bed. We would go to an early tracheostomy or perhaps just extubate the patients altogether, and the patient can be managed on ECMO with the ICU nurse. There's still a need for the ECMO team, but they're the backups, and they're there to deal with transportation and triage and emergency problems. We've also learned it was a mistake to try to recruit the lung by increasing the pressure for periods of time. That simply caused pneumothoraces and other problems. So we've learned to just be patient, watch and wait, which means that most of these patients, if it's a respiratory failure, will go through a period where the lung doesn't work at all for a few days, even a few weeks of time, but still recover at the end of it. And bleeding is an annoying problem, but now a minor problem, no longer a lethal problem. Veno-venous access nowadays is usually achieved with this double lumen catheter made by a company called Avalon and now made and manufactured by McKay. And you can achieve veno-venous access by draining from the femoral vein and reinfusing via the jugular vein, and that works perfectly fine, and it's the way to do it if you have to get on in a hurry, because placement of this device requires being in the cardiac cath lab or at the very least very good C-arm radiology. But we drain blood out of the the superior and inferior vena cava, pump it through a membrane lung, and back through a separate lumen of the same cannula into the right ventricle. We monitor the things that are listed in these boxes, calculate the other things, and use that information to decide how to manage the extracorporeal support. In recent years, we have learned that it's better for these patients to get up and out of bed and exercise, and this began with the bridge to lung transplant patient. This is one of Chuck Hoop's patients from 2009, demonstrating that patients could get up out of bed, could exercise, and became a much better candidate for transplantation, and that has now extended to all of severe respiratory failure. With ECMO, it's pretty easy. With a patient who's dependent on high pressure, high oxygen, it's more difficult. But the whole idea of mobilizing patients, waking them up, getting them out of bed, or at least exercising in bed, has permeated through all of adult critical care now, largely based on this experience. I mentioned the physiology earlier on, and this is just to point out that the membrane lung is made to function at a normal hematocrit, 48, a normal hemoglobin, 45. So all of you are subject to this idea that it's okay to be anemic if you're sick, and if you're really sick, you ought to be really anemic, and I would argue that's a mistake. Hopefully that will go away one of these days. But at least with ECMO, you have the option of either increasing the hemoglobin by transfusion or increasing the flow if you want to achieve a given level of oxygen transport, and I would argue that it's much safer and simpler to increase the hemoglobin than the flow. This has also led to a lot of studies in interventions, particularly ECMO, in acute fatal illness. It's the only life support system that has been studied in prospective trials, and in fact, there have been 10 such trials that I reviewed, and I put this up if you're interested in that topic. I'll give you an example of just a couple of them. One is conventional 50-50 randomization, the study that was done in the UK several years ago, powered for 300 patients, finished at 180 patients because of significantly better survival in the ECMO group. This is the Kaplan-Meier curve for that study. This is 28-day outcome, 76 versus 50% survival. This is a different trial, also done in the UK, looking at H1N1 patients only, and looking at patients that were managed in ECMO centers versus patients matched for diagnosis and severity of illness from non-ECMO centers. You can see a rather remarkable difference. The same was true in the French study of H1N1. There's real evidence now that this is worth undertaking despite the expense and the risk. And in fact, the latest definition of ARDS includes ECMO as the option to treat if other things are failing. So finally, a couple of words about the future of this technology. The things that we are currently doing are in yellow here. So we have simple automated devices. We have modular components, not only for cardiorespiratory failure, but for renal failure. We just plug a hemofilter in if needed. Nowadays, you can plug a MARS system in for liver support if necessary. These are the things that are coming and we're working on in the laboratory. We need to get to the point where there's no systemic anticoagulation. With the current system, if you have trouble with bleeding, you can turn off the anticoagulation. You run the risk of clotting in the circuit, but you can manage patients for days this way without having systemic bleeding. We're using the technology for ex vivo organ perfusion, and because of the results in respiratory failure patients, we're recognizing a need for lung failure units where you can manage a dozen of these patients for months at a time. The applications are in ARDS and all these other things I've told you about. We're interested in the use of this technology for systemic sepsis. We're working on an artificial placenta for very premature lambs in this case, and finally leading to implantable artificial lungs. So 10 years from now, the future of this, as I see it, will be what we're doing now, but probably more ECPR for cardiac arrest, acute circulatory failure for other reasons like sepsis and exsanguinating hemorrhage, and the application to organ donation has really become quite an interesting topic. The ECPR application is quite successful. These are pediatric patients from the registry, but the survival rate for ECPR, that is ECMO-assisted CPR, is about 30 to 40%. As you know, the survival rate otherwise is about 5%. So there's a lot of interest in this. There's a group in San Diego that's really been the first to implement a full protocol in their emergency room, run by the emergency room docs, including the cardiac surgeon. You all know Walt Dembitsky. And they developed a protocol for doing this. In their first evaluation, they had 42 patients who were on CPR, 18 met the protocol, 10 of them improved, some failed, but 8 patients were resuscitated on ECLS, 5 of them discharged from the hospital, 61%, neuro intact. This is growing a lot in emergency rooms around the world, and you as cardiac surgeons are going to be asked to participate in this, but the key to it is to get your ER docs to learn how to cannulate and get started, which they can do with percutaneous techniques. Over the next 10 years for respiratory support, we'll be doing all the things that we currently do. There's interest in selective CO2 removal, which you can accomplish with this approach, and we'll talk about that in a minute. And we're now getting into the idea of using ECMO for chronic respiratory failure, particularly bridging patients to transplant who would otherwise be taken off the list because they have an exacerbation. And we're focusing on diaphragmatic hernia, as I mentioned, and bronchopulmonary dysplasia in children. There's a lot of current literature in the critical care literature, and you're probably hearing about it, of selective CO2 removal using extracorporeal support only to remove CO2, which has been around since the 70s from Ted Colombo and Luciano Gattinoni and all, but it's every couple of years it has a resurgence of interest for the right reasons. It's a very effective way of treating status asthmaticus, for example, or COPD in severe exacerbation, patients who don't really need oxygenation, they just need CO2 removal. There's quite a lot of interest in using this in ARDS with the intention of minimizing mechanical ventilation, realizing that the device at low blood flow won't support oxygenation. Finally, we have learned a lot about the reversibility of severe lung failure. When we did this, and as you did it, you have a patient been on for 14 days, 20 days, 30 days. Why are we doing this? This is irreversible lung damage, and you simply turn it off. The group at the Karolinska in Stockholm said, well, wait a minute, why are we doing that? Let's just keep going to see what happens if we support these patients. Here's an unusual patient, but a patient that's becoming a typical patient, a young man, you can see here, with his friend on full support with 0 lung function for a month. But his brain works, and so they kept going, and here's his tidal volume coming back, and this patient recovered to normal healthy lung function in a fairly short time. This is a picture of Dr. Chris Nelson, who's here today visiting with us, and her little patient who's at Johns Hopkins. This little girl has been on ECMO for actually more than 14 months and is recovering and is about ready to come off at this time. So what do we make of this? This is really an interesting phenomenon. We've learned that the lung has unexpected regenerative capacity, and with prolonged extracorporeal support, can recover after weeks, months of time back to totally normal function. So we're in a new era now. We're learning about the regenerative and the recovery issues that relate to the lung, which will lead to practical problems. Suppose you have a dozen little girls like the one I just showed you. Where are you going to put that patient? In the hospital? You're going to take up the ICU, so the cardiac surgeons can't operate. That's not going to last very long. So the idea of how to deal with this in the long term is an interesting challenge in medical practice. But if you think about it, it's exactly what we do with acute renal failure. We just put the patient on dialysis and wait for 6 months. Or we put a VAD in, and a lot of those patients will remodel and recover cardiac function without needing a transplant. So we're in an exciting time in medicine. Well, finally, I told you about this patient from Indiana. It turns out he was captain of the gymnastics and cheerleading team, and the football game between Indiana and Michigan was in the fall of that year, and he'd recovered enough to lead his team out onto the field. This happened to be in the big house, and he led the cheerleaders for Indiana, but we warned him that he's now full of maize and blue blood, so despite his cheering efforts, Michigan won the football game. So thank you for the opportunity to present this. I'd be glad to answer any questions.